Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
This is episode 2 of our series, Gender Bias in Healthcare, Consequences and Solutions. My name is Scott Giles, and I'll serve as your host for today's episode. I'm pleased to welcome Dr. Candace Pierce from Elite Learning. Dr. Pierce is a nurse with more than 15 years of experience working at the bedside, in management, and in nursing education. Dr. Pierce did a fantastic job in episode 1 of introducing us to the topic of gender bias, including its manifestations, historical roots, and the impact on patient care and outcomes. In this episode, we will discuss real-world solutions, from policy changes and improved medical education to practical steps healthcare providers can take to ensure they're delivering care that's fair, equitable, and free of bias. Candace, I'm very excited to talk to you again today, and I'm particularly excited to move to solutions because I think there are many solutions potentially available that we'll discuss today. Again, not just at the patient level, but the provider level, the policymakers, the organization level, and there's a lot to discuss. So if it's okay with you, I think we're just going to jump right in.
Absolutely.
Okay. Candace, what are some of the effective strategies in healthcare that healthcare professionals can use to recognize and address their own implicit bias? Because I think, to me, that has to be one of the first steps in terms of making this less theoretical and real to almost all individuals at some level.
Absolutely. And one of the things that I always tell my students and everybody that I work with is we have to know how to self-reflect. And for biases, biases come from where we were raised. It comes from our community, all the things that are around us. And so a lot of times they just become almost innate, it seems like. And we have to be able to be willing to engage in regular self-reflection. And then we have to actively acknowledge that there is a potential for bias in our clinical decision-making. We got to find where it is. Because I guarantee you, most of us have it. And now we just got to find it so we can get rid of it. You can do this by validating. There's these validated implicit bias tests. You can take those tests online. There are some that are free. And they'll be able to kind of give you an idea of the areas where you have biases. You could keep a decision-making journal where you can kind of track your patterns during your patient interactions to help you personally identify, would I have done this differently if it was a different patient, or would I have thought about this differently if it was a different gender or age? There's also decision-making protocols that kind of help you with justifying your clinical choices on that objective criteria rather than your more intuitive judgment, which kind of goes back to those implicit biases.
And do you feel that the typical provider is aware of these resources or engages in these resources? Because it's like anything, right? If you're interested in a topic, then you can go find, all kinds of these inventories, these analyses, these ways to reflect on your own implicit bias. I actually did one of these surveys, which I found really interesting.
Yeah.
But again, I probably wouldn't have done that if the topic wouldn't have even come to my mind, or it wouldn't have made it that far up my list to do in order to engage in that. But I did because I knew we were going to be talking, and I found it to be super interesting. But what is the mainstream clinician doing to even self-reflect on these pieces?
Well, honestly, it's going to depend on what state you live in too, because there are some regulations, some statewide regulations that are now requiring education on implicit biases.
Ooh, I like it.
Like Michigan is an example of one that was requiring implicit bias training for healthcare providers. So it is starting to become talked about more. But if you're in a state where you're not seeing this, you're not going to know that it's here unless you just unless this podcast just falls in your lap, or, some other article falls in your lap. If it is something currently that most providers are having to seek out themselves. And I hope that they do. I hope that when they go in and they do their I need to go do my continuing education, and they type it in, they see this as an opportunity. But at the same time, how likely, were you or I going to be like, oh, that looks interesting. Let me take this implicit bias course, you know.
Yeah, sometimes things like that, again, not that people don't see the value, but people are so clinically skills focused in many cases, right?
Yeah.
Or you're doing something that you view as much more unique to the individual unit that you're working on or your patient
Yes.
population, as opposed to some of these more global communicative or affective
Mm-hmm.
type domain pieces. Sometimes
Mm-hmm.
self-reflection too is a little bit harder, and I'll speak for myself on that,
Mm-hmm.
than it is to maybe stay more objective or mainstream, right? But the truth
Yeah.
is, a lot of us, including myself, could probably benefit from exploring areas like gender bias and other associated areas
Mm-hmm.
that maybe aren't quite as sexy, but
Mm-hmm.
could make you a more effective provider, quite frankly, than reviewing another continuing education course on a specific clinical
And
skill.
that's something else that you could do, is like having some participation in case reviews with other diverse colleagues. That's going to help find some of these potential bias blind spots, and
Right.
really help with providing some constructive feedback. But again, those are things that we need to talk about. You will see that some larger organizations will have training or mandated training on implicit bias. But at the same time, self-reflection, it needs to be directed self-reflection. A lot of times, especially in nursing school, when you teach on undergrads, there's a lot of self-reflection that happens there. But it's like, oh, write down about your clinical experience today. But we don't really give the direction of, what should I look at? What should I reflect on? And this is an idea of something they could reflect on. Did you experience something that maybe someone else would have experienced differently from a patient's perspective, but also from a healthcare provider perspective within yourself?
Yeah, no, I agree. And, sometimes, you'd like to think the organizations would be more proactive to this topic, but
Mm-hmm.
again, they have a lot of things that are on their to-do list as well. But one of the other facts that I came across that I thought was interesting is that, 75% of the healthcare, maybe 70%, but 70 to 75% of the healthcare workforce are females, but yet
Mm-hmm.
only like 20% of the senior management tends to be female. So
Yes.
again, I'm not suggesting there's some big coup
Mm-hmm.
here, but I do feel like it that
Mm-hmm.
since males have been kind of, I don't think there's as much male bias,
Yeah.
as perhaps female bias. Then maybe the importance of this topic is not that anyone's malicious, but it's that it
Mm-hmm.
may not be in their mind as near a big a topic as it might be for a female in senior management. So
Right.
I think that needs to
Well,
change as well, right?
and as leadership, within leadership, because I've been in leadership at a hospital, but why do women, they're basically told to make yourself smaller so I can make myself bigger, you know? And I really feel like that's a huge reason why you see only 20% women in healthcare leadership versus the 80% men. Um, if you and I went into the same type of conversation with the same tone and said the same things, we would be interpreted completely differently.
Right.
Mm-hmm.
Yeah, there's absolutely some truth to that. I mean,
Mm-hmm.
regardless of the kind of the composition of the administrative hierarchy in
Mm-hmm.
terms of male, females, I mean, what do you feel are like the minimal things that, even baseline things that every organization should have in place in order to, keep or bring this issue to the forefront?
Well, so if we're looking at creating like policies and practices, really
Mm-hmm.
that's what we're going to be looking at with organizations. And you can really take this kind of two ways. You can look at it from that healthcare leadership, because it's all about the culture that we set. And then it's also how we take care of our patients. So for kind of both of those directions, the answer really is comprehensive policy reforms and structural modifications. So, you can also spend that for the care that the patient receives as implementing several patient-centered policies and practices to reduce gender bias in direct patient care. But that's the areas where we see it happening. I can take that further if you want.
Well, do you think, because again, things that get acted on are
Mm-hmm.
usually things that people can acknowledge and have data to show that it is a problem. Do you
Mm-hmm.
feel that most large organizations are tracking outcome data at a gender level that even allows them to know that, Houston, we have a problem here?
Mm-hmm. No, absolutely
Yeah.
not.
I thought that might be the answer to that question. I
Yeah.
mean, that's a problem, right? And I mean, in episode 1, you provided the example of, signs and symptoms of heart attack. And I mean, there are some real things that you don't have to be a rocket scientist or go too far, to recognize that there are serious implications of mismanaging something, an emergent condition based on gender, or not considering signs or symptoms to be different than the classic signs or symptoms, in these kind of scenarios. So it's kind of too bad that, and I know it's a very hard thing to do, but it is a shame that there's not more, definitive data that could be pointed to, because if, again, once it reaches that status, action tends to occur. Otherwise, it almost has to be, someone has to, take it on as a passion project, or they just have to be the voice to bring this forward in order for it to get the, the time and the attention of other folks in management, as far as it,
and there is
tricky.
data. And there is data, and there are metrics of how you, as a healthcare provider in, say, a big organization, how you can speak to your leadership. It's that data and those metrics that really are going to paint the picture so that others see that it really is an issue. Because if they don't see that it's an issue, then they're not going to start tracking, and they're not going to start trying to make a difference. So, you could track gender-based differences in treatment decisions. You could track outcomes. You could track patient satisfaction scores. You could even track resource allocations. You could track wait times, because it has been documented that women end up waiting longer in ER waiting rooms than men. So you could actually document and analyze wait times, referral patterns, pain management approaches, and even the frequency of the diagnostic testing orders across gender groups. So there are a lot of things that you can actually look at to get a really big picture and really analyze those metrics, and start looking for, say, patterns of bias, even just informed targeted interventions, because it's not even just bias for gender. You could see bias for race. You could see bias for age. You could look at bias against different symptoms even when they come in. So that can really give you a big picture. But also, like I said in our first episode, pulling in that qualitative data, bringing in that patient feedback along with your quantitative data, and that's going to give you an even bigger picture.
For sure. No, and I think you provided some really tangible data that could be, easily collected. And I think you could draw some inferences from that, or at least be the basis to, have a discussion with people. Well, why is it that women, wait 15% longer on average? Why is it that men 15% more of the time are prescribed, pain medication than women? Or, I don't know. I mean, that, to me, the identification of and there could be other reasons for that, perhaps, but one of the reasons is kind of what we're talking about. So it's healthy to engage in those kind of discussions, I think.
And you can make that data as granular as you want it to be, and start connecting other dots, like they're female and they're young, they're female and they came in with symptoms that could have correlated with a heart attack, so you really could make that as granular as you wanted it to be.
Sure. And with the data management systems in place today, that's not even a stretch, right? You just have to care enough to ask the question and put another field in, right? As far as that goes, because obviously we collect all kinds of data on every patient in every scenario. One of the things that I think about with any form of bias, in terms of it changing healthcare providers' behaviors, comes down to the educational setting. And that if things aren't important or perceived as important, or don't perhaps command the necessary amount of time in an educational setting, then oftentimes these skills don't transition over to clinical practice. So to me, the real change agent, or one of the most effective long-term ways to change gender bias or any form of bias, is to make sure the schools are doing a great job and moving this through their curriculum, and not just in terms of discussing the topic, but we talked about before, differences in biology between men and women, difference in physiology between men and women, and how it impacts disease diagnosis, et cetera. Where do you think schools are on that continuum? I mean, I know every school would say, yes, that's very important to us, but in practicality, how's this playing out at the educational level? Do you have any sense?
Well, I would ask, how much time do we spend in a classroom versus how much time we spend working with other people who are already in the field? In
Mm.
nursing, you do a lot of clinicals, and med school, when they get towards the end of it, they're doing a lot of residency time. And so your education not only comes in that classroom, but a lot of your beliefs and your thoughts are going to be, it's almost like I'm going to go hang out with you, and how you think is going to rub off on
It's
me.
true.
And that's where we see those generational pass downs, unfortunately, in healthcare, and where maybe they weren't taught this in school, but they learned it at the bedside, unfortunately. And I'm not saying that it was a bad doctor. I'm not saying that they were
Sure.
intentionally trying to be a bad healthcare provider, a nurse, anybody that interacts with patients. But a lot of times it's how we pick up habits from others. And so, you were talking about how important education and training is, and like it's pivotal. It is a pivotal role in mitigating gender bias, because education and training lays that groundwork. So I think we could do a better job of really hitting on this. But again, this is really starting to become heard more. Women are getting louder to say,
Good.
hey, I don't think it should be like this. I don't think I should have to sit here and go through this horribly painful treatment without having something that helps me. Yeah, women are trying to stand up and say and to be louder, but it has to go, like you said, it has to go beyond just simple awareness to actually learning how to practically incorporate the skills. We have to develop the skills of self-reflection. And you know what? You could do self-reflection last month, and this month you don't realize it, but you picked up another bias. You were
Sure.
hanging out with someone else. And so it has to be a continual process of being made aware that this could potentially be a problem, and then evaluating how you treat patients and how you take care of patients, and developing those skills to be like, well, let me take a step back. Let me change my behavior towards these patients.
Right, for sure.
Mhm.
Do you know if as far as the accreditation standards for educational programs, do you know that if there are specific criteria linked to addressing biases in healthcare? And
Mhm.
is that something I know
Mhm.
as a physical therapist in the physical therapy curriculum, I mean, the accreditation standards are endless and deal with things
Mhm.
like cultural competency and a number of things that
Mhm.
they didn't used to deal with. They become much more broad in terms of being sensitive to some of these issues. Do you know is that a requirement within the nursing accreditation criteria, or even are nurses assessed on that knowledge when they're taking their licensing exam?
So cultural competence is taught. It is something that is discussed. I can't speak for every school that's out there, but it should
Sure.
be. And going through accreditation, usually you'll have to be like, this is how we teach. But again, that's cultural competence. That's
Right.
different than
It
gender
is. It
bias.
is.
Yeah.
And I'm
Um,
not saying that, I don't know how far that drills down, but that was just the
mhm,
cultural competence piece was something that, that I know
mhm,
for a fact that, for instance, in the
mhm.
PT accreditation criteria and even on the licensing exam, but that
Yeah.
gets tricky too, because, you want to avoid stereotyping, you want to avoid,
Yeah.
so again, things that aren't objective, things that are more affective domain issues
Hmm.
are sometimes not as easy to address in accreditation criteria or licensing exam, et cetera. And you bring up a
Yeah.
great point about the role modeling piece, because that's huge, right? Because to some
Hmm.
extent you can learn anything in the school, but if you go out in the clinic and you're not seeing that emulated, those things tend to fall off the wagon pretty quickly.
They
So
do.
yeah,
Yes.
we really need
Well,
both pieces for that to be
and
effective.
one of the things that I really want to point out, that if there's an educator that's listening that's interested in how can I help students to understand this and see it, is case-based learning is a great way to
Mm,
really bring in those real world examples of gender bias. And that's going to actually help with providers, nurses, whoever, with actually recognizing more of those subtle forms of discrimination, because a lot of times that bias is going to be very subtle, hardly recognizable to a lot of us, unless you're the one that is affected by it. It's
right.
not subtle to us when we are being affected by it,
Sure.
but if I'm the one that's doing it unintentionally, then it's probably going to be more subtle to me. I'm not going to realize that I did it. So, doing some regular workshops, even on effective communication, shared decision makings, bringing another person in to be like, hey, this is what I wrote down. This is what I've assessed. And this is what I'm thinking. Can you double check me to see if I'm missing anything?
No, that's good. And I mean, you're right. At the individual level, by people who are passionate about this, or people just know they'll be a more effective clinician if they can eliminate any form of bias, not just gender bias. To bring it up, to ask for in-servicing on this information, to bring in someone from a speakers bureau who's an expert in this topic. All of those things, I think, go a long way in order to do that.
Yeah.
What about gender sensitive communication? Do you have some thought? Because obviously that's very much related to gender bias as well. But do you have some recommendations or thoughts in terms of that topic?
Yeah. So of course it goes back to our inclusive language where we're not making assumptions, active listening, because a lot of times we listen to respond. We don't listen to understand. I've already made up my mind. So I'm just letting you talk, but I already know what I'm going to say. I've already made up my mind. So that's not a healthy way to assess somebody. So we got to practice active listening, validating patients' concerns, regardless of their gender. Just like when I was telling you about my stomach issue, and I kept saying that something's not right. This is not right. And yet I was just automatically dismissed every time. And we don't need to do that. We need to actively listen. We need to acknowledge, and then we need to assess. We always need to assess. And this is going to really help us with avoiding some of those gender-based stereotypes that we kind of talked about in health discussions, and really make sure that the patient can receive thorough explanations of their conditions and treatment options. You don't just be like, oh, here he goes, what I'm about to do to you. Here we go. Also, our nonverbal communication can shut a patient down really fast.
Oh, so, definitely.
If your nonverbal is not matching what you're saying to me, it's going to shut me down, and I'm not going to feel that I can talk to you, which means that I might actually have a delayed diagnosis because you didn't hear everything that I needed to say to you.
Right.
And then I also want to take you on a little rabbit hole again, if that's okay.
Yeah, let's do it.
But we're talking about gender bias. But what I want to do is tell you about some other biases that can be coming along for the ride.
Okay.
So, all right. So some examples would be anchoring bias. And anchoring bias is like a tendency to make a decision or a judgment based on your initial information rather than taking all of that information, gathering all the information that you need. And so a good example of this would be making a diagnosis based entirely on the initial symptoms rather than also looking at the subsequent symptoms that they might be talking about. There's confirmation bias. And that's where you're choosing to review only the information that is in favor of the decision you've already made, that belief that you already have. So if you believe my stomach pain is due to psychological distress rather than a physiological issue, you're going to only choose to review the information that is pertinent to your previously established diagnosis. That means you're dismissing anything else that I say to you that does not support your diagnosis.
I think we've seen some of that in the political sphere recently, right? In terms of people taking in information. But I mean, you can see that
supports.
Yeah. Well, see, of course I was right?
Yes.
But when you said that just reminded me of that.
Bias.
It is.
That's exactly what it is. I mean, these biases are not just in healthcare. I mean, I'm defining them within healthcare, but just like you're saying, confirmation bias means that what I just heard on this news channel, I'm only taking the bits and pieces to support what I already believe.
Right.
And you've got confirmation bias. And then another one that speaks for itself is going to be overconfidence bias. Totally speaks for itself, doesn't it? That's where my confidence is completely misplaced, because in actuality, I'm overestimating my ability, my knowledge, and my understanding of what is actually happening. An example of this would be a provider who is he was certain I needed to see a psychologist for my stomach pain. And so he's correct in his diagnosis, and he refuses to order any additional tests to ensure that he's even correct, to ensure that this diagnosis is accurate, or to even consider other forms of treatment, or to even thoroughly assess the patient for other possible diagnoses. So, I mean, gender bias, I would say is kind of the start that leads into some of these other factors that can potentially keep you from providing high quality care to either gender, depending on the situation at hand.
I mean, without self-reflection and,
Mm-hmm.
self-assessment, I mean, I don't know how people who have some of these biases, I mean, how
Mm-hmm.
you can be an effective clinician, right? I
Yeah.
mean, it's just,
Yeah.
you can't leap. You have to move methodically. You have to go through the
Mm-hmm.
process at any
Mm-hmm.
level. You have to provide, people the level of the doubt, or the benefit of the doubt. And it's interesting too, because when you talked on the last episode, we were talking about kind of different biases. And then it wasn't just really like, well, how do we deal with this bias? How do we deal with that bias? We kind of made the point that, look, you're dealing with stacked biases here. So, I
Yeah.
mean, you know, any, any belief becomes
Mm-hmm.
multiplied by numerous biases that become even
Yeah.
more difficult to assess, or maybe even more difficult to be aware that you're making the decisions that you're making, because
Mm-hmm.
you can't make good decisions if you're not informed about your blind spots. And clearly, I
Right.
think we've demonstrated this is a blind spot for many people. I mean, are
Well,
there some support services or resources that are kind of your
mm-hmm.
favorite for someone
Mm-hmm.
who, either recognizes maybe this is an issue for them, or just for someone wanting to be like, I don't think I really have gender bias, or I don't think I
Yeah.
discriminate against socioeconomic status, but I,
Mm-hmm.
let's kind of assess that objectively. Are there some things that
Yeah.
you'd recommend for people?
Absolutely. But what I will say is if we don't know what biases we have and which way they're swaying us, then we can be blind to how we are actually treating our patients. And how we treat them is either going to cause an erosion of trust, so they're not going to seek care in a timely manner, or we can build trust so that they do seek care in a timely manner. So it really does matter how we treat people. But as far as resources and support systems, first, I want to preface this with saying I'm not recommending any platform that I share here. I think that it's important for you to do your own research, talk to the companies to find your best fit if you're interested in using any of these, because there are a ton that are out there. So just because I say their name, I am not recommending any
Sure.
platform that I share.
We'll
But
put in the disclaimer.
yes, but you do see that we have clinical decision support tools and some mobile apps like UpToDate and Dynamed. And those, they can provide evidence-based guidelines for more of your gender-specific symptom presentation and treatment protocols. So that's
Okay.
really helpful with recognizing and appropriately responding to conditions that we see that we know um, present differently across genders, such as like heart disease, autoimmune, mental health disorders. They're really helpful because they include built-in prompts and checklists to help you with ensuring that when you evaluate them, it's a comprehensive evaluation, regardless of gender. You also have some medical reference databases and specialty specific resources. And these are things like PubMed and Chanel,
Mm-hmm.
Cochrane Library. And those are going to provide you more of your updated information and gender differences in, say, disease manifestation, drug responses, treatment outcomes. A lot of times you can find case studies and some of those, like we always call them the clinical pearls, that
Right.
highlight some of those common pitfalls that we see in gender bias diagnosis and treatment. So that's what those are good for. We also have professional societies that offer clinical practice guidelines that really incorporate the gender specific considerations when it comes to patient assessment and care planning. You'll see that with the, always get the acronym letters wrong, AMWA, American Medical Women's Association.
Okay.
The Society for Women's Health Collaborative. There's also the Society for Women's Health Research. There are point of care reference tools too, like the LexiComp and the Micromedics, that where you can pull up like gender specific drug dosing, side effect profiles, monitoring requirements. AHA, they have gender specific cardiac care recommendations. The World Health Organization has actually some gender specific considerations for things that are looked at more globally. The American College of Obstetricians and Gynecologists, they also are starting to include clinical guidelines specific to women's health concerns. Um, and then there are some free resources. Medline Plus through the National Institute of Health, they usually have some good stuff on there. There's a lot of articles about women's health and the history and how we kind of got to where we are on the National Institute of Health, if you're interested in looking at that. The CDC has some clinical tools that you can find. World Health Organization also has some free ones online. And then there's the Agency for Healthcare Research and Quality, where you can find some clinical resources and guidelines as well.
That's amazing. And I did happen to look at the Office of Research on Women's Health, which is a research division of NIH. And there are all kinds of free resources on that. And actually, that's one of the places I did one of these inventories that I thought was different. So look, if I think what people are hearing is that if this is a topic that's important to you, or you believe it can make you a more effective clinician, which I think we all believe that, the opportunities are endless, and many of these will not cost you a nickel. So the investment's, undeniably strong as far as that. So we both encourage you to link to that. Candace, I really want to thank you. This 30 minutes has gone super quick, and this is a topic that, we could talk about for hours. But as we conclude today's conversation on strategies to reduce gender bias in healthcare, it's clear that while significant progress has been made, much work remains to be done. Reducing gender bias in healthcare isn't simply about changing systems. It's about changing mindsets. It requires collaboration among patients, providers, organizations, and policymakers. For more information on topics like gender bias, implicit bias, or many other topics, I encourage you to explore the continuing education courses available at elitelearning.com. Candace, thanks again for joining us today, and thanks for our listeners for tuning into this episode.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.